For your information, on the right-hand side hall, the posters exhibited by postgraduate students is already there. Someone interested can have a visit before going. Thank you.
Ifatu Huda.
Next, we have a prize distribution to the kids of yesterday's cultural events. First one, Huda, who is the daughter of Dr. Rifat. I invite Dr. Obi Madam to give away the prizes.
Good afternoon all. I would like to welcome Chairperson for the next session, Dr. Anup KJ, Family Physician, Medical Officer working in Kerala Health Service. Welcome sir to the dais. Dr. M. Sunil, who is currently working as Consultant Family Physician in Usha Cardiac Center, Hyderabad. Welcome to sir.
Hello. Okay. Welcome to the afternoon session of the second day of AFPICON Kerala 2025. The first talk on today is Aesthetic to Medical Understanding Nail and Hair Conditions. And it will be presented by Dr. Robi K. Prasad, who did her MBBS from Government Medical College, Calicut. And after that, PGDF from CMC Vellore. And she's a member of Royal College of General Practitioners of UK. She's the founder and consultant family physician at the Robi's Family Clinic, situated at Kozhikode. The dice is for you, madam.
Okay. Thank you, Anu. Good afternoon. So now we'll have some talk about hair and nails. I guess we'll talk something about hair and nails because it's just 15 to 20 minutes, so I don't know how much I'll be able to convey. I'll try my maximum to give you some information which will be useful in your clinical practice. So understanding the hair cycle is very important. You know, there are 3 stages of hair growth, the anagen phase, catagen phase and the telogen phase. The longest being the anagen phase, which lasts for few years. The catagen phase is the shortest and telogen phase lasts for 1 to 4 months. Why is it important that you should know the hair cycle? Is because most of the conditions that cause hair fall or hair loss normally causes an acceleration in the anagen phase, and the hair quickly passes into the telogen phase and you have a shedding of the hair. So that is why the hair cycle understanding and the hair cycle is important to us. And you know, a lot of hormones and so many factors that influence the hair growth. Among the hormones, androgens are the most important. The hormones, growth factors, cytokines, neuropeptides, nutrition, the general condition of your body, the seasons, all influence your hair. So the common hair problems that we come across are hair loss, breaking of the hair, change in color, change in texture, thinning, and more hair, like that is hirsutism is like another problem. But we won't have time to discuss all this. So let us stick on to the major problem that we all come across, that hair loss. So what is excessive hair loss? We all have subjective feelings that, especially ladies, when they lose 10 strands of hair, they say they have a lot of hair fall. So up to 60 to 100 hair strands if you lose per day, even that is considered a normal. So what you can say is, tell the patient is to collect as much as hair as possible, especially when you comb, and you ask them to collect in 24 hours. Okay, ask them to collect in 24 hours and take a count of it. If it is more than 100, maybe they are genuinely having a hair loss. Otherwise, you can consider it as normal. And another 2 important signs that you can look for is widening of the partition line and visibility of the scalp through the hair. Okay, other things like cigarette smoking, alcohol, stress, poor circulation, all these are, and genetics of course is very important in hair loss. Now when you categorize hair loss, it is non-scarring and scarring. The scarring part we are not much bothered about because the follicles are already lost. We have nothing much to do in that. So we are more concerned about the non-scarring part of it. And in the non-scarring thing, the androgen alopecia, telogen effluvium and the alopecia areata are of more concern to us. So whenever you take a history of the patient with hair loss, you always ask about the onset, the duration, precipitants. You look for the pattern, diffuse or patchy, whether the scarring, shedding, breaking, thinning. Medical history is very important, especially of recent illnesses, drug history, family history, how they care for their hair, and diet is the most important. Right? Because it's become a lifestyle among the youngsters. So whenever you see the patient with hair loss, the first question that you ask them is whether are you on a crash diet. That is the most important cause for hair loss nowadays, especially in the youngsters. Now first we talk about androgen alopecia. When we talk about hair loss, what we are more concerned about is androgen alopecia and the telogen effluvium. So androgen alopecia is more genetically mediated, and the telogen effluvium is a common hair loss that we come across, like after an illness, postpartum, all that comes under telogen effluvium. So it is very important that you distinguish between androgen alopecia and telogen effluvium. Though the treatment modalities are almost the same, it is essential that you differentiate between the two, because the telogen effluvium, it might recover, or the hair loss might stop after some time, and it might recover automatically also, but this does not. So you have a male pattern and a female pattern of androgen alopecia. In male pattern, you have the receding hairlines and you have an M pattern, but female normally loses, there's a thinning of hair, and the central hairline becomes more visible. Both types, in both males and females, you are normally, it occurs gradually, and you have a predictable pattern for that. You can see the patterns of hair loss in females and male. In males, the thing is they can become completely bald, but the females normally don't become completely bald. That is the male pattern, and this is the female pattern of androgen alopecia. Androgen alopecia is due to androgen excess. Actually, in puberty, during puberty, when the androgens normally stimulate hair growth, okay, but as you grow older, when the androgen is in excess, it causes the follicles to shrink and lose hair. So it is a condition of androgen excess actually. So what do you investigate? Both in androgen alopecia and in telogen effluvium, you have to investigate like hormone levels. You can see like thyroid, iron levels, then better to see a PSA level before you start on finasteride. Okay, so coming on to the treatment aspects, whether it is the androgen alopecia or telogen effluvium, the treatment, first what we can do in our setup is the topical minoxidil. Topical minoxidil is the one that we all use nowadays, and there are 5% and 3% minoxidil available. Normally 5% for males and 3% for females, but nowadays we use 5% for females as well. So how you use it is, you use 1 ml twice daily for few months, like up to 6 months you can use twice daily. They are available as with droppers or as sprays also. So exactly they would say how many sprays will make 1 ml. So you use 1 ml and you rub it onto your scalp twice daily. You don't have to wash it off, just leave it like that. And after 6 months, initially there will be a hair fall, and after that it starts improving, and after maybe 4 to 6 months you can switch on to a maintenance dose of once daily that you have to continue for maybe 1 or 2 years. But it is always found that once you stop using minoxidil, in the next few months again you have a hair loss. So how far it is beneficial is again a big question. So but that is one thing you can actually start in your clinical practice. You can use minoxidil. And oral finasteride is also, nowadays the minoxidil and finasteride together as combination is available. That is also available as topical applications. And some other things like rosemary oil, all that is becoming popular. There are studies which shows marginal improvement with rosemary oil. Right. Another newer modalities that we now follow are the platelet PRPs, and there is another one called the GFC PRP. That's the growth factor concentrate PRPs are there. So PRP, how do? You take your own blood is drawn and it is centrifuged twice, and then you get a PRP, just like what we do in our blood banks. Okay, and that is injected into the susceptible areas. So that you have to do at least 4 to 5 sessions in around 4 to 6 weeks apart. You have to do so many sessions. And the difference between the PRP and this is how you instill the PRP. And this is the GFC PRP, that's the growth factor concentrate PRP. For that, what you do is there are ready-made kits are available, and that contains a separated gel. So you can draw blood and you can put it into this vacutainer, and it automatically gets separated. The growth factor automatically gets separated, and then you can instill it in your scalp. Okay, the whole treatment will cost around 5,000 to 6,000 rupees. And if you are using an imported kit, that might cost up to 10,000 rupees per session. Now, something about hair transplant. So you all know hair transplantation has become very popular nowadays, mainly because the cost has come down. Initially it was 7 to 8 lakh rupees. Now you can do it in less than 1 lakh or maybe 1.5 lakh. You can get a hair transplant done. So the donor area is your occipital area. From the occipital area, they take the grafts and they put it onto your scalp wherever you want to do it, the area. So first you mark the area. There are two main types of hair transplant. That's the follicular unit extraction and the follicular unit transplantation. Okay. So nowadays FUE, the follicular unit extraction is more popular. For the follicular unit the transfer, you have to take a strip of hair from the occipital area. Around 10 centimeter strip is removed, and then the strands, the follicles, the hair strands are removed, follicles are removed one by one, and then transplanted. The other one, they take it out as a follicular unit, and that follicular unit is as such transplanted to the area. So the first one, the FUT requires a suture, then suture removal and more of infections and all that. The other one is less of infections. The procedure as such is very tedious, and if one actually 2,500 grafts will cost you around 80,000 rupees. 2,500 grafts will be enough to cover your forehead. Most of the persons will require just 2,500 grafts, that's all. But if you are completely bald, then you might require up to 4,000 grafts. 4,000, then still it will be less than 1.5 lakh rupees. But it has its own complications and things. It is a long process, and if you have more grafts, you might even require 2 days, 4 to 6 hours each day. and you require a lot of local infiltration and nerve block, and you have to have an anesthetist ready if you have anaphylactic shock and complications to handle. So you should have a good setup. That's about the telogen effluvium. As I told you, the fever, postpartum, crash dieting, thyroid function, dysfunctions, iron deficiency, all these can cause the normal hair loss. We have already mentioned the treatment. Actually, both the telogen effluvium and the androgen alopecia have the same modalities of treatment. But first thing always you do is supplementation. You can supplement iron supplements, the B12 and biotin. Biotin is the most important thing that you give for hair. In our diet, the best things that you can give for biotin supplementation is broccoli is something that's available here. So many things like pork chops and all that we don't get here. Salmon, all these things are not available. They are actually very rich sources of biotin. What we get is beef liver, something like that. You can suggest as supplements. Now what is this? This also is something that you commonly find in your clinical practice. That's alopecia areata, yes. Alopecia areata it's an autoimmune disease. It's genetically, actually it is a combination of genetic and environmental factors that cause the disease. Right. Again, this can be managed in our clinic with a minoxidil, topical minoxidil. Most of the patients recover with minoxidil treatment. In 2 to 3 weeks itself, they have considerable improvement. So, you can go in for other agents like anthalins, then steroid ointments, topical steroid application can be tried. If you are not, there's no improvement, then you can go for steroid instillations, injections of steroid injections, but we don't normally do it. You normally refer to a dermatologist for the same. Okay, and systemic therapy also you can go for the immunosuppressant drugs can be used, and this oral Janus kinase inhibitors are a newer modality of treatment in alopecia areata, but we rarely use it in our practice. For completion's sake, though it's scalp condition, tinea capitis. Tinea capitis just mentioned because you have to differentiate it from alopecia areata. Tinea capitis normally you find it in children, more in children, and siblings will also be affected. You will have itching, and this one, scalp psoriasis, yes. So if you have tinea capitis, the treatment modality will be completely different. You have to go for antifungal shampoos, oral antifungal agents can also be used. Right. What is that? Traction alopecia. That's a traction alopecia just because of the hairstyle. So first thing you tell them is you change your hairstyle. But still that area that they have lost, it might not come back. Right. This is quickly about the shaft diseases. Just the important one that we see, that's pedra. People say kaya, mudi kaya, and they come with all the complaints like that. So that is pedra. That you have black pedra and white pedra. And pedra, it affects all, not only your terminal hairs, not only your scalp hair, it can affect your pubic area, axillary areas, everything can be affected with pedra. So what do you do? That's a black pedra and this is a white pedra. Okay. Shaving is the best, actually. Shaving is the best way to get rid of pedra, but it may not be always possible. So you can use all the antifungal shampoos and creams can be used. And if it's not resolving, you can go for oral antifungals like terbinafine, itraconazole, all that can be used. And prevention wise, you ask them to discard all the infected underwears and to dry the hair properly after washing. What is it? This is just to make it interesting, that's all. It's an uncombable hair syndrome. That's just, you normally find some kids, it's normally in the childhood and by around 12 years it disappears. But we have a very important personality with this syndrome. Any guesses? He had uncombable hair syndrome. Right. Now, just few words about premature graying. Premature graying can be due to that. This is one of the most common things that the common complaints of youngsters nowadays, premature graying. So I normally tell them it's normal. Even if you're 20 years, it is normal nowadays because the level of stress they have is such. Like pollution, smoking, stress levels, health conditions, all can cause premature graying. And also autoimmune disorders, vitamin B12 deficiency. One thing that you should not miss is vitamin B12 deficiency. Always ask whether the person is on vegetarian diet, and you look for the counts, you look for a megaloblastic anemia whenever you see a patient with hair premature graying. Okay, that is one thing you should never miss. And quickly about nails, I told you there are time constraints, so I'll just tell you just the important things. Right. You should know the time of growth your nails take. Fingernails it's 3 to 6 months, but the toenails it's 12 to 18 months. So whenever you treat nail conditions, the treatment should last till then, till the growth is completed. Especially on onychomycosis, all that whenever you treat, you might have to treat till 6 months to get the best results. Okay. Diagnosis. Don't sleep. Ingrowing toenail. Okay, so you know the treatment, right? All of you must have seen ingrowing toenail. You give them just for the relief, you can give them a course of antibiotics. You can use some topical antibiotics like mupirocin, and ask them not to hinder the nails too much, not to disturb it too much. But ultimately you need a nail removal, and if you are lucky, you will get the new nail will be normal. Otherwise, the new nail that comes also might be the same condition. So that happens sometimes. This is a very, very common condition. In childhood, we used to say we get new dresses, right? When you have white. So this is leukonychia, and there are a whole lot of conditions that cause leukonychia, like trauma, allergies, fungal infections, medications, poisoning. So you have to look for the cause and treat the cause. So as such, this doesn't have any treatment. You have to look for the cause and treat it. Okay. So according to the thing, you have to give fungal, antifungals, or correct the malnutrition. Right. This one, acute paronychia. We must all be doing drainage of acute paronychia in our clinics, right? I normally use only a needle. I don't use a scalpel or anything. I don't give a block. I just poke it with a sterile needle and give it a small compression bandage so that it does not collect again. Otherwise, the second day the patient will again come with the recollection of this. So just give it a small compression bandage so that it does not recollect, and you give a good course of antibiotics, it will be gone. Okay. So if they are diabetic patients, please be more careful because it might spread very quickly. Even if you give a course of antibiotics, it might spread. Okay, and nail care is most important. Always you advise the patient to avoid very close trimming. You ask them to leave the sides. Okay. Don't make it round, and don't trim it very closely. Close trimming is the most common cause for paronychia and all that. And do not pull the cuticle. Okay, all that is the one that causes. Right. That is fingernails, toenails, onychomycosis. Yeah, this is very commonly seen in and sometimes you might need a nail clipping, right, for the diagnosis, but mostly it is like clinical, right? Okay, and what do you give? What I normally give is fluconazole. I give weekly once 150 milligram of fluconazole, but it has to be continued for maybe 3 to 6 months. But definitely most of them improve. Very rarely, if it is very severe infection, very generalized infection, it might not improve. Then you can go for itraconazole. Itraconazole daily once 200 milligram, 2 to 3 weeks. Right. This is Psoriatic nails. Psoriatic nails I just put because you have to differentiate it when you get onychomycosis and psoriatic nails. Okay, just two more this thing this is brittle nails. Brittle nails are actually very common, and it's very benign also. You actually don't need to treat it. It is normal in aging, but you can supplement it like zinc deficiency, iron deficiency, hypothyroidism, retinoid therapy. All these can cause brittle nails. So, good supplementation can help. Okay. These are horizontal ridges. Horizontal ridges are normally benign. You don't have to worry much about the horizontal ridges. Okay. But these are vertical ridges. Vertical ridges are something of concern. Okay. I said, I think I confused it, right? Sorry. Right. Yeah, the horizontal ridges are the problematic ones. Horizontal ridges, mainly the Buse lines, right? So, in that case, you have to be careful. These are all horizontal ridges. These are all the ones that you are. See, there's a Buse lines. Buse lines are normally, you find it in peripheral arterial disease, zinc deficiency. Zinc is actually one good supplement that you can give for all your nail and your hair conditions. Biotin and zinc supplementation is very good. What is this? One more nail. Half nail, Lindsay's nail, mostly found in renal diseases. Actually, they improve with transplantation. After transplantation, they improves, but doesn't improve with hemodialysis. It does not improve after hemodialysis. Okay. This last thing. Ladies must be familiar with this thing. Newer things. Artificial nails. These are actually acrylic nails. So I just came across this very recently. They apply a mixture of liquid acrylic monomer and acrylic powder to the natural nail, and it just solidifies to an artificial nail. So it's a permanent thing actually. So when your nail grows, this thing also extends out. So you can shape it and you can keep it permanently. You don't have to remove it. But actually then the extension of this is like polygel nails are also available. It's also the same. There's a material difference, that's all. Okay, so such nails are there, and a lot of side effects, like allergic reactions to that material, acrylic material itself. When they harden, it can cause even an allergic reaction. Nail damage to your normal nails might get damaged. You can get fungal infections, bacterial infections. All these health issues are there because for all these nails. So if somebody asks you, see, most of the things I described here, the transplant, the PRP, we are not going to do it in the our clinic setup, but you might have patients who come and ask you for advices, what is to be done. You can guide them correctly. So that's why all this has been included in this talk. Okay, thank you so much.
Thank you, ma'am, for the enlightening talk. Requesting chairperson to call up for the next presenter. Over to you, sir.
Yeah, thank you, ma'am. It was a very nice talk. Next, we'll move on to talk on congenital and corneal conditions, practical approaches for general practitioners by Dr. Krishna Kumar PM. He is a specialist family physician from Health Services, Government of Kerala. Over to you, sir.
First of all, thank you to the organizing committee for inviting me for this talk after 5 years. First of all, we will start with the conjunctival and corneal conditions. You can notice the last word for general practitioners. That's the catch in it, because I am presenting only the things which we need, not to the ophthalmologist. Okay. Usually in OP we will be surprised or frightened to see an eye case, right? We will be seeing the patient, oh, this is eye problem, okay, go to the ophthalmologist, that's all. We usually don't treat, right? Unless it is a conjunctivitis also, we will not be treating the patients. But some conditions we can treat. That's what I am saying this. Some are normal. We can assure them that it is normal. Okay, that's what I am going to tell you. What is this? Ice. I think it's eyes of a beautiful lady, right? So I think eyes are the most important part in a human body, right? Right? It's not for vision, but also for the beauty and the looks. That's all. If one macula or any white pigmentation on his eye, everyone will be asking you, right? Everyone will ask. So that everyone will notice first your eyes. So the most important thing is the eye. So we have to be more cautious or more conservative on the eye problems. This all of you know, the cornea, and just I put it there, that's all. Then about the conjunctiva. Conjunctiva is just a mucous membrane with two parts, bulbar and palpebral components. Just it is lying on the cornea. Okay. Why it is important? Why it is important? You all know the eye has only contact with the conjunctiva to the periphery because the peripheral everything will be first in contact with the conjunctiva only. So conjunctiva will be more strong, right? But it is a delicate membrane. But we can prevent all the infections through that delicate membrane. For that, the body has provided so many blood vessels in between that. And also, there are the blood vessel means, the blood vessel, if any allergen comes to the conjunctiva, then all the blood vessel will be congested. Congested means there will be more blood flow, more WBCs, more immune components. So, if any problem to the eye will be red, right? That way, the eye will be red. Even if it is a allergen or a infection, it will be red. Okay, that's why it becomes red. And also, it will be yellow at time of jaundice. Is it sclera or conjunctiva? It's more yellow. The explanation is that it is conjunctiva because it has more affinity to that bilirubin because of the elastin which is present in the conjunctiva. Okay. Hereafter, some pigmentary lesions on the eye. There are some melanocytic nevi, and also we are seeing some subconjunctival hemorrhages, and also you are seeing red eyes because the only cornea will be black, the rest of the sclera you will see as red. There are so many things which we have to tell the patients because there will be subconjunctival hemorrhage. We have to investigate for that reason of the subconjunctival hemorrhage. Never do anything to the lesion. Okay, means never drain or never puncture conjunctiva or anything. These lesions may be intraepithelial or epithelial or subepithelial. These are excessive melanotic pigmentations. So there is nothing to do with the melanotic pigmentations. If it is involving the cornea, means sclera, then you have to investigate for that. You have to send the patient to the ophthalmologist. Okay. Other causes, this just added for the completion's sake, Gaucher's disease, acropnuria, Cartagena syndrome, Peutz syndrome, all are presented with some pigmentation in the eyes and conjunctiva. Then it's our common bread and butter of family medicine, that conjunctivitis, which is the only thing we are treating well. Because as I have said, if anything allergen comes or any infection comes, there will be more blood supply. The blood will be coming to eye, so there will be congestion and more immune complexes. Main symptoms are swelling, itching, and burning, redness, increased tear, sensitivity to light, a discharge or touching of eyelids. These are the main symptoms I will tell you in detail. This slide I have put to make you know about the family physician's role in conjunctivitis. Because the main role is to prevent the spread and to avoid spread to the family members, and also if they are going to the workplace or school, if one outbreak is started in a school, it will continue to spread all over the classes and everyone will come with conjunctivitis. So if one person is coming with conjunctivitis, we have to educate the mother and the child about the eye hygiene. That's the most important thing in family physician's role. Otherwise, we will treat the patient with some other medication, we will diagnose it, we will treat it. But we will not tell them how to prevent it from spread from one person to another. So wash your hands, avoid tearing items, and wash always with a fresh cotton ball and discard it, and change the pillow and bed sheets, and use disposable contact lenses. Okay. Then what you practice at home to prevent the spread to family members. This is more important. Just read it carefully, because it is the most important thing you have to tell. And one more important thing, we as family physicians never tell the patient to check their vision if they are coming with any eye problem. That I have seen, previously I was also like that. Then I have found so many patients coming with eye problems, coming with congestions, because refractive errors are very common. They will come with congestion and eye pain, watering, everything. So it's very important. So if any patient comes with eye problems, check their vision. Okay. Don't touch or rub the eyes. Wash your hands often with antibacterial sanitizer. Avoid wearing makeup. Is it possible? Avoid wearing makeup? I think it's not right. But we have to stay at home and avoid wearing makeup is okay, right? Never share makeup. That women will not do, I think so. Anyway, remove contact lenses for that time and wear spectacles. And artificial teardrops are very effective in viral conjunctivitis. Protect with glasses or anything to avoid exposure from dirt or any pollen or any allergen. But usually, in previous practices, patients will say how we look to other patient's eyes, because it will spread on looking to other person's eye. It's it's a myth actually. So you all know it will not spread from looking at to one other's eyes. So, and apply clean warm compresses over the eye. That's very important. Then about allergic conjunctivitis. We have to differentiate it between 3 conjunctivitis: allergic, bacterial, and viral. There will be much more itching in allergic conjunctivitis. Allergic conjunctivitis, there will be much itching. Viral conjunctivitis, there will not be that much itching. Bacterial conjunctivitis, there will be more crusting and more secretions. The eye will be full of crusting, and eye will be, I think, will be joined together. You cannot open the eye in the morning. You can also, if there is more itching, it will be allergic conjunctivitis. Less itching with edema, with a lot of secretions, it will be viral conjunctivitis. Bacterial conjunctivitis, there will be more secretions, more crusting. Okay. Then, by allergic conjunctivitis is usually associated with rhinitis, asthma, or eczema, and usually bilateral involvement. That there will be clear mucoid discharge, conjunctival edema or chemosis. You will be seeing some water inside the in between the conjunctiva and cornea. You have seen, right? Most of them you have seen. That's why I told there is not much new in this presentation, but you all know this. We have to refresh. That's all. Mild eyelid edema will be there, and also allergic conjunctivitis is recurrent because there are seasonal variations are there, and also there will be papillary changes in the eye. This is one. Is it clear? That will be papillary changes. That much right. Treatment, mainly cone compresses, oral antibiotics. That's the main treatment, because even if there is more watering, more edema, then we can use steroid eye drops if it is severe. That's all. Otherwise, avoid steroid eye ointments, because in HSV conjunctivitis and all, if we are using eye steroids, then there will be scarring. Then we can use the eye drops. Cannot, is it clear? Olapatadine eye drops, it's very effective than steroids. Okay. There may be preauricular retinopathy associated with the pharyngitis will be there. We can see in my OP also there are so many patients with pharyngitis and conjunctivitis. That will be viral conjunctivitis. That's by adenovirus. Usually no itching, but there will be itching sometimes. The follicular conjunctivitis is viral origin. Usual viral treatment is arterial tear drops, but it will resolve in 10 days usually, within 10 days. Isolation is important because it will spread person to person. This is much more, little bit severe conjunctivitis here, HSV conjunctivitis. Mostly HS1 is in adults and HSV2 in neonates. Usually there will be lid vesicles, URI, gingivostomatitis, keratitis. 80% cases are unilateral. There will be cloudy cornea will be there in that. The dendritic ulcers are the most hallmark of HSV infection. You can see that. These are the dendritic ulcers. You can see that there. This you all know. What is that? Herpes. Herpes also causes conjunctivitis. Then bacterial conjunctivitis. I already told there will be much more secretions, usually in infants and toddlers. Papillary response is there. Associated otitis will be there. These are you can see the secretions crusting, and the eyes are joined together. This is papillary conjunctivitis of bacterial allergic origin. They just put a slide to show you the pseudomembrane formation. There is a pseudomembrane formation there. This is ophthalmia neonatorum, in which you can see I have put the arrow, that is a copy of secretions, and this is the secretions in the eye of a child. Maybe bacterial, chemical, viral. Then, can you differentiate it from this? The middle, there will be so much of secretion, right? That is bacterial, right? Then edema will be there in third, right? more conjunctival edema. That is viral. Upper is allergic. And also there will be vitamin A deficiency and vitamin A excess causes corneal and conjunctival issues. In cornea, this time is less. You can symptoms are foreign body sensation in the eye, itching, redness, intense pain, burning, sudden vision changes, light sensitivity, blurring or cloudiness. Most common causes are infections, trauma, allergies, dryness, and corneal dystrophies. Most common issue we are facing is in the OP, dryness. We are always patient coming with eye itching, usually with diabetic patients, that's dryness. Usually artificial tear drops will help them. Other one is welder's eye. Welders will come with welder's eye. That also, one more thing, with foreign bodies they will come. With the foreign bodies. You can see the foreign bodies in the cornea. And previously I was picking it up with the needle and all, but now I am not doing because of that. Some litigations coming, why you are doing these things. If something happens, patient will be on us because eye is the most important organ in our body. Now I stop that. Then I told you, myopia, hypermetropia, astigmatism, that because of the changes in the shape of the cornea, these all will come. So, testing of vision is the most important thing if a patient coming with eye issues. Then injuries, abrasions will be there, keratitis will be there, corneal edema will be there. This may be, causes may be ultraviolet or any chemical. Cloudy cornea will be there. I have also already HSV conjunctivitis and glaucoma because I put it there because you have to overthink about these conditions also. Acanthomic conjunctivitis looks with cloudy cornea. The last ones in the corneal and conjunctival disease are pincicula and pterygium. These all, you all know these things. The pincicula will not be involving the cornea, but pterygium will involve the cornea. That's the difference between pincicula and pterygium. Pterygium extending up to the cornea, into the cornea, but pincicula will not be affecting the cornea. Okay? So I think it's thank you. I have put only things which is essential for the general practitioners.
Thank you, sir, for the eye-opening session. Now I request the chairpersons to call up for the next presentation. Over to you, sir.
Thank you.
Hello. I think this is the end of the session now. We'll take up 1 or 2 questions from the audience. Any questions from the audience? I think no one, no.
So if there are no more questions, we'll wind up the sessions. I kindly request the chairperson, Dr. Sunil and Dr. Anup KJ, to present the memento to the speakers. Dr. Ruby Prasad. And Dr. Krishna Kumar P. To present the memento to the chairperson, I would like to invite Dr. Indu ma'am. To hand over the memento to chairpersons, Dr. Sunil and Dr. Anup.
Next, there's a prize distribution for the cultural activities done by kids yesterday. I request Indu Madam to give away the prize to Neelol Pal, son of Dr. Ambili.
We'd also like to present a memento to our workshop facilitator, Dr. Bijoy Matthew. I kindly invite Dr. Bijoy onto the stage and would request Indu ma'am to present the memento to Dr. Bijoy. Thank you, ma'am. So we are moving on to the next session. To chair the next session, I would like to call upon the chairpersons, Dr. Biji Joseph. He is a consultant family physician and medical superintendent of Rivershore Hospital. And to accompany him, Dr. Jashira, senior specialist in family medicine, Astor MIMS Calicut. Over to the chairpersons. The first talk in this session is From Policy to Practice, NTP Updates for Family Physicians. To speak on this topic, I would call upon Dr. Melvin J. Gonsalves, Specialist Family Physician, Health Services, Government of Kerala. Over to the chairpersons.
Tuberculosis is a major public health problem, especially in third world countries like India. Family physicians can play a vital role in prevention, diagnosis, and treatment of tuberculosis. Today we have Dr. Melvin J. Gonsalves. He graduated from Government TD Medical College, Alappuzha. He did MD in family medicine from CMC Vellore. He did a diploma in community mental health from CIP Ranchi. Presently, he is employed with Kerala Health Service and posted at Cherthala, Alappuzha. He has 3 publications. He is medical officer for TB control in charge of Cherthala TB unit. Over to you, Dr. Melvin.
Good evening, everyone. So, I'll be taking the topic on NTP updates for family physicians. First, we'll start on with the SDGs, also known as Sustainable Development Goals. The United Nations framed 17 SDGs, and out of these 17 SDGs, the third one being related to health and well-being. So in the third SDG, related to TB, what is mentioned is regarding what is the vision is zero TB death, zero TB disease, and zero TB suffering. And the goal is to end the global TB epidemic, that is less than 10 cases per 1 lakh population. So these are the 2030 SDG targets. That is 90% reduction in number of TB deaths compared to 2015 data, 80% reduction in TB incidence, and zero catastrophic expenditures related to TB for TB affected families. Actually, what I'm presenting is just the tip of the iceberg. It's a very vast topic, so I'll have to move in a fast-paced manner. So I'll just go in briefly. So based on the global TB report to in 2024, NTB strategy 2025 milestones to be attained is 50% reduction in TB incidence rate, 75% reduction in number of deaths, and zero catastrophic costs. On an average, for a drug-sensitive TB case, the expenditure incurred is around 2,000 rupees, and for a drug-resistant TB case, the expenditure varies from 9,000 to 1,20,000, depending on the duration. So the crucial thing here is detect TB early, and in order to obtain a successful outcome. Else, this incurs a lot of cost, especially even though the treatment is free of cost to the patient, but it's a big burden on the country's economy. You can see on the map the estimated TB incidence rates in 2023. Where India stands, it is incidence per 1 lakh population per year is around between 100 and 299. So the TB-Free India campaign was launched in 2018, and India committed to end TB by 2025. That is 5 years ahead of the global SDG target. So even though India committed to end eliminate TB by 2025, we are lagging behind a bit, mostly because there was COVID outbreak. So the activities were stalled in between. So this is regarding the, this picture shows the evolution of NTP. In 1962, the National TB program was set up. In 1997, NTP was revised to RNTCP. In 2005 to 2011, the second phase of RNCP was implemented. In 2012 to 2017, NSP, National Strategic Plan, was set up with mandatory notification for TB and introduction of rapid diagnostic tests. In 2017 to 2025, patient-centric care for TB elimination was given more focus. And in 2020, RNTCP was revised to NTB. And 2021, TB Mukt Bharat Abhiyan was launched by our Honorable PM. So what is this National Strategic Plan? So there are 4 components, that is detect, treat, prevent, and build. That is find all TB cases, reach out to all the vulnerable groups, treat all TB cases with high-quality anti-TB drugs, and prevent the emergence of drug-resistant TB, and build and strengthen supportive systems. So first component, detect. What are the strategies involved? That is vulnerability mapping, active case finding, early detection, and scaling up of rapid diagnostic tests. That is, all cases should have universal coverage for drug sensitivity testing. The next component is treat. Treatment part is fixed dose combination drugs which are available as a daily regimen. Then sustained treatment success rate of more than 90%. There should be injection-free treatment regimens and scaling up newer drugs. Then prevention part, this is the main highlight of NTP. Along with the treatment, we are giving more focus on prevention. So, importance of cough etiquette, airborne infection control among health facilities, then contact tracing and TB preventive treatment. Then build includes capacity building, multi-sectoral collaboration, IECs, HR development. So last month, this intensified 100 days campaign was launched. And what are the targets? In 2023, the TB incidence rate in India was 195. So this year, the target is to reach below 50. And TB death rate to reach below 5 from 22. So what are the key challenges here? That is a low TB testing rate. And most of the people, that is 60% of the symptomatic, did not seek proper treatment, timely treatment. And 46% TB patients are undernourished. So the main goals are to accelerate the case detection, reduce mortality, and prevent new cases. You can see these are the 347 high focus districts, and Kerala is marked in blue. That is, all the districts are coming under high priority. That is, there is high death rate and low testing rates. So coming to the signs and symptoms of active TB, mainly we focus on four symptom screening. So cough more than 2 weeks, hemoptysis, fever, night sweats, fatigue, unexplained weight loss, chills, loss of appetite, chest pain, or pain with breathing or coughing. So an untreated TB case can transmit to at least 10 to 15% per year. And contacts of an active TB are at 10 to 60 times higher risk of developing active disease. So here lies importance in finding the cases early and providing treatment at the earliest. So next we move on to the integrated management algorithm. So we screen for vulnerable groups. Vulnerable groups, those who are at high risk of getting TB infection. So there's a presumptive TB case. Those who are having symptoms, we classify them as presumptive TB. We obtain sputum samples, send them for microscopy or CBNAT or Gene Expert, TrueNAT, and chest X-ray. So if microbiologically it's not confirmed, but if chest X-rays indicate suggestive of TB, then we start treatment, taking it as clinically diagnosed TB. And if microbiologically confirmed case, and if there is rifampicin sensitivity, if suppose we do sputum microscopy, and if it is positive, next step is we go for drug sensitivity testing. So that is CBNAT. But the recommendation is upfront CBNAT. But because vulnerable population is very huge, so our resources won't be enough to test everyone using first-line CBNAT. So, when possible, we do sputum microscopy. Then, if it's possible, then we do CBNAT for ruling out rifampicin resistance. Next is, if our resistance, then we'll send the sample for LPA, that is first-line line probe assay. It can detect both rifampicin as well as isoniazid resistance. And if both are sensitive, we treat the case as drug-sensitive TB. If there is rifampicin resistant, we send sample for first line to confirm the same. And again, if it is resistant, then we'll check for second line drug resistance. That is, we send a sample for second line LPA, line probe assay. And if second-line drugs include fluoroquinolones, and if fluoroquinolones are sensitive, then we treat the case as MDR-TB, and if FQ is resistant, then we treat the case as XDR or pre-XDR TB. If only isoniazid resistance is there, then the case is treated as H-mono or poly-DR-TB. So these are the various treatment regimens which is being followed now. For drug-sensitive TB, we have the 6-month regimen. We have 2 months intensive phase and 4 months continuation phase. For the intensive phase, we give HREZ. H is isoniazid, R for rifampicin, E ethambutol, and Z is pyrazinamide. The next slide, we look at the doses. And for continuation phase, we have HRE. For H-mono regimen, we have 6 months of levofloxacin, rifampicin, ethambutol, and pyrazinamide. In both drug-sensitive TB as well as drug-resistant TB, the treatment duration can be extended. Like in extrapulmonary cases, we can extend from 6 months to 1 year, depending on the site. For MDR, we have shorter oral bedaquiline containing regimen and oral longer TB regimen. These 2 regimens are used. And the shorter oral regimen contains bedaquiline, that is for 4 to 6 months, we can do bedaquiline, and 6 months levofloxacin, clofazimine, pyrazinamide, ethambutol, high-dose isoniazid, and ethionamide. For oral longer regimen, 18 to 20 months, levofloxacin, bedaquiline, linezolid, clofazimine, and cycloserine. So for drug-sensitive TB, this is the protocol which we follow now, based on the weight band. That is, for adult category 25 to 34, 35 to 49, 50 to 64, 65 to 75, and more than 75. So we have fixed dose combination drugs, that is HREZD, each tablet containing 75 mg isoniazid, 150 rifampicin, 400 pyrazinamide, and 275 ethambutol. And in continuation phase, we have 3 FDC. For pediatric less than 18 years, we have weight band ranging from 4 to 7, 8 to 11, 12 to 15, 16 to 24, 25 to 29, and 30 to 39. Only difference is in pediatric FDCs, ethambutol is available as a separate pack, and usually the FDC contains 3 drugs, HREZ. In 25 to 29 weight band, usually 3 pediatric FDC plus 1 adult FDC is given, along with 3 ethambutol tabs. These are the various regimens for TB preventive therapy. So I'll just mention TPT in detail, because this is the mainstay of our ATP program. Because we are not only treating the active case, we have to do contact tracing, find out who all are having TB infection or latent TB infection. So what is TB infection? That is 30% of the contacts of bacteriologically confirmed pulmonary TB patients develop TB infection. And among these, 5 to 10% develop active TB. Among infants, it is 50%. And 1 to 5 year age group, it is 25%. And what is latent TB infection? So among TB infections, 90 to 95% develop TB in later stages of life, when host immunity is compromised. So these are the patients with latent TB infection. So in order to treat latent TB infection, TB preventive therapy is provided. And who all are eligible for TPT? That is all household contacts of bacteriologically confirmed PTB all people living with HIV and children living with HIV above 1 year. CLHIV less than 1 year in contact with active TB, then other risk groups like those on immunosuppressive therapy, silicosis, anti-TNF treatment, dialysis, organ transplantation patients, etc. What are the contraindications of TPT? So before starting preventive therapy, we should always rule out active TB. We should confirm whether the patient is not having active TB. Then other contraindications include acute chronic hepatitis or patients on hepatotoxic drugs, heavy alcohol consumption, peripheral neuropathy, and allergy to any drugs in the regimen. And pregnancy or past history of TB or renal disease is not contraindicated for TPT. So this is a state policy for TPT regimen. People living with HIV and child with HIV 6H daily for 6 months. This was a previous regimen followed for children, actually. Now it is only for these two categories. Now for children below 5 years, we have the 3RH regimen, that is daily for 3 months. And for 5 to 15 also, we follow the same regimen only. The only difference is for 5 to 15 years, we do IGRA testing and confirm whether they are having latent TB. Below 5 years, we don't need to do IGRA testing. All below 5 are need to take this TPT drugs. Then above 15 years, we have the 3HP regimen, that's weekly for 3 months, so 12 doses. So 3HP is isoniazid and rifampicin. This is the dose chart. So always look for ADR like hypersensitivity reactions, hepatotoxicity, rash, GI upset. So this is the 3HP regimen for adults, that is 3 months of weekly isoniazid and rifampicin. So state recommends this for more than 15 years. Isoniazid dose is 900 and rifampicin dose is 900. 12 doses are given. Always, while patient is taking TPT, we should look for any signs of active TB. Now a new test has been introduced, that is CYTB. So instead of IGRA, this has been launched. It is similar to TST, but it is more specific. Next is the risk assessment parameters. These are the 16 parameters you should look into every month when the patient started on ATT. And based on these 16 parameters, you can put scoring. And if the score is more than 3, we need to refer the patient to a tertiary unit. To consider hospitalization in the following cases when BMI is less than 14, or severe anemia or unstable vitals, any complications of PTB, or any drug-induced hepatotoxicity seizures. So in these situations, always refer the patient for admission. So next is the documentation part. There's a web portal known as Nikshay. So all those patients who are referred and treated are enrolled in this web portal, Nikshay. And there is a helpline also, 1-800-11-6666. Then there is one Nikshay Poshan Yojana for all TB patients. It is, from this November onwards, it has been revised to 1,000 per month. So they get 6,000 for 6 months treatment. Then for private providers notifying TB, they are paid 500 on notification and 500 rupees on successful outcome. And another mainstay of NTB is transformation of TB survivors to TB champions. That is capacity building and mentoring program. So we can utilize these TB champions to raise awareness of TB, reduce stigma in the community, carry out advocacy, and provide emotional and social support to the people affected by TB. So that's all. Thank you.
Thank you, sir, for the enlightening session on NTP. Now I invite the speaker for next presentation, Dr. Nishant Menon. Over to the chairpersons.
I would like to welcome Dr. Nishant Menon. He have done his MBBS MD Emergency Medicine from Government Medical College, Kannur, and Fellowship in Family Medicine from CMC Vellore, Fellowship in Critical Care, and fellowship, he is a Fellow of the Academic College of Emergency Experts in India and certified in Biostatics. Okay. Today he is here with us to present on invisible illness, navigating chronic fatigue syndrome.
There is a
Sorry
change
for
in
that.
the order of topics.
Can you put on this?
Yeah, this is the topic.
Sorry for that. His topic for presentation is handling acute emergencies in the OPD. I would, okay, on to Dr. Nishant.
Thank you. So, yeah, I know everyone is into some slumber. Even I feel a bit dizzy. So, without wasting much time, we'll just move on with a few case scenarios that will make youngsters, residents more interesting and glued to the topic, I feel. So these are a couple of cases which came to the fast track OPD where I'm working. This case actually came last month, that's last year. And we'll also discuss one more case which came this year, that's this month. So this is about a 30-year-old lady who presented with complaint of lower backache for one day. So I'm not just presenting a case, but I want you all to travel with me in the same thought process. Let's see how we solve the case. So vitals, everything was stable. The respiratory rate was 16, but heart rate, BP, temperature, pulse, everything was normal. So with that, of course, like most of you, my thought process was also going to the lower backache being more orthopedic, maybe a muscle spasm because she's a young lady, right? Okay. So then came a detailed history where I got a history that right-sided lower backache has been there for one day and it is severe in intensity. I think the pain score was 7 and she was not complaining of radiation of pain and it was associated with 3 episodes of vomiting. So as you all know, severe pain abdomen is associated with vomiting. That could be a calculi related pain or any severe pain can cause vomiting. So again, I was thinking of maybe a query renal or uteric calculi presenting as a back pain. Then she complained of this pain relieved on bending forward. So again, that was confusing. Any other differentials do you have? Pancreatitis. Okay. So upon examination, everything was fairly okay. Chest was good, CVS was good. Per abdomen was a bit distended, but not really tender. Bowel sounds were present. Then GCS and everything was normal, no neurological deficits or anything, and absolutely no spinal tenderness or paraspinal tenderness. So what are your differentials? Can anyone just shout out? Somebody said pancreatitis. Okay. Aneurysm. Okay. Good. So that is like there are two probable approaches to this case. This is probably option 1 and option 2. Those are two streams of thought. Most of the general practitioners would opt for option 1 if the pain subsides. And then more aggressively, maybe we could think of option 2. Okay, I went with option 2. Some of you actually shouted dissection, so of course, you would also think of option 2. So I took, I planned for X-ray, but you know what? Pregnancy. Yeah, I'll come to my approach later. So this is just an option which I gave to you. So this is the emergency medicine thought process where we think more broader. So again, there comes the abdominal aortic aneurysm, which could be an atypical presentation, renal disease, pyelonephritis, calculi, and peptic ulcer, pancreatitis. All those things are included here. So coming back to the case, as it happened, it is pain. So you have to relieve pain. So we started with injection paracetamol, a safe thing, safe bet if I'm thinking about pregnancy. Then pain persisted. The score was somewhere around 7 and 6. And then we gave another injection, lornoxicum, NSAID. Then our order is like to go for an ultrasound first because you need a full bladder. And once the ultrasound is done, they'll probably go and pass urine. At that time, you ask them to collect urine samples and send for UPT. So all those things done. Then it has to go for an, after ultrasound, it goes for urine routine. So internal echoes in urinary bladder was pending. We were thinking of probably something like cystitis, but pending the reports. UPT was negative, but severity of pain persisted. So we actually rushed for an X-ray abdomen. And X-ray abdomen showed this. Okay, so we all were thinking about aneurysm. We were all thinking about pancreatitis, but surprisingly, it came out like this. What is this? That is the sigmoid volvulus, the coffee bean sign. And this patient actually ended up for an emergency surgery consultation and a laparotomy. So leave all those. I'll move on to the next case, a similar case of a 26-year-old female who presented with complaints of chest pain since 2 days. Okay, there was associated vomiting. And the vitals were this. Any red flags which you find there? Yeah, tachypneic and tachycardic. Otherwise, everything was normal looking at least. So what are the differentials which come into the minds of young family physicians? Okay, so in detail, the complaints of chest pain was again for 2 days, radiating to lower chest on both sides and also to the back, associated with 3 episodes of vomiting. And she was complaining of it exacerbating on lying down, whereas it got relieved when she was sitting. Then there was history of fever and cough, but only white mucoid sputum, and there was history of rhinitis 1 week back. Is it relevant? Query relevant? Is it irrelevant? We're not sure. Then menstrual cycle day 3. So moving on to the examination, we found that the trachea was shifted to the right side, and then air entry was increased on the left side. Any differentials at this point? Effusion, pneumonia, pleuritic. Okay. Because my resident told me this history and said there's no air entry on the left side, there was tachycardia, I actually went and percussed and found that it was something like a pneumothorax. So my impression initially was catamenial pneumothorax because it was the menstrual time, and my residents are looking at me like, okay. So, of course, like most of you, we were also glued to this system, the pulmonary system, and we were all thinking of the probable diagnosis, leave alone the lung cancer because it was a young female. Again, somebody reminded me of Yuvraj Singh. So that was again a DD. Coming back to the patient, the pain score initially was 9 out of 10. We started directly with injection tramadol, but pain persisted. It was somewhere around 7. And with these differentials, we took an ECG and chest X-ray because an MI in the young needed to be ruled out, and pulmonary embolism had to be ruled out. So what is this? Sinus tachycardia. Again, that doesn't rule out pulmonary embolism. But then chest X-ray showed this. Chest X-ray, again, at the look of it, looks like a hydropneumothorax, but then we found that it is not actually a hydropneumothorax. That is a diaphragm pushed up. And bowel had actually eventrated. It was a posterior diaphragmatic hernia with collapse of the left lower zone and a left minimal pneumothorax along with it. So that again went to the surgeon and a laparotomy was done, hernia repair was done. So I'm not giving cases which present as something and finally end up as being something else which doesn't cross your minds. Okay, so we'll just recap the classic teaching when it comes to abdomen, because we have discussed 2 acute abdomen cases. Acute abdomen is a condition that demands urgent attention, and it could be of any etiology. But patient usually presents with sudden onset of abdominal pain, and most of the patients will be sick or looking ill. But pearls from these 2 cases, which came walking or the fast track OPDs, were that there could also be cases which could be acute abdomen without having the symptom of pain abdomen per se, and diagnosing such things could be challenging. Okay, so we need to actually think about satellite symptoms of early acute abdomen. That is one aspect which I wish to actually mention. And from a GP point of view or a family medicine point of view, when you're in an OP, chest X-ray could be the easiest and the most life-saving intervention which you could, life-saving in the sense not just the patient, but also of the doctor who has missed a diagnosis. Okay, so a chest X-ray would actually be helpful in identifying most of the conditions when it comes to acute abdomen. An erect chest X-ray, if there is an air under the diaphragm, or if there is something like a volvulus, most of the times you will get a clue to it from a chest X-ray taken. Okay, so that I would also like to mention about the other aspects of the paradigm, like pain abdomen presenting to you as pain abdomen, like patient presenting to you as pain abdomen, but finally turning out to be medical diagnosis like a sickle cell crisis, diabetic ketoacidosis, acute porphyria, pyelonephritis, hepatitis, pancreatitis, etc. Okay, so with that, I just take away those two cases and we'll come to the topic proper, which is how do you approach patients coming to your OPD being a case of an emergency, like the patient should have gone to the emergency department but wrongly came to you as a GP in the OPD. So you need to understand what is urgent care and what is emergency care. Urgent care is like it can be dealt with in a fast track OPD or by a family physician or a GP or whoever is in an OPD setup, whereas emergencies most of the times require an emergency setup where you can give multiple IM, IV medications, you can monitor the patients, take an ECG, you have a bedside echo, ABG, blood investigations at your disposal. So that is something which you need to understand. Broadly, I can say that emergency medicine is in emergency room or in the emergency department. Family medicine is in the OPD and urgent care is somewhere in between. Okay. So this is a hoarding in the highways of Australia where they differentiate or they educate patients and bystanders with regards to what is emergency care and what is urgent care. But you know, people just come here as and how they like. This is again something from the NHS where people are waiting in queue in front of the GP. Of course, somebody who is coming with severe chest pain shouldn't be there in the queue. So you need to identify the patients who are coming to the OPD with classic symptoms, which could be red flags in itself. Such patients should never be in queue waiting for their turn to meet you. So that is the first lesson as to triage your patients. It could be a staff nurse or whoever is doing or whoever is taking note of the vitals. Like the second scenario which I mentioned, if the respiratory rate is high and if the heart rate is high, then definitely that patient should be given more of value than what the token number is. Okay, coming back to the cases which we discussed, not the cases per se, but a young female coming with chest discomfort or palpitations maybe. We'll take it as an example of a medical case. And while in a GP mode, when in the OPD, you would think of the most common diagnosis as the most common diagnosis. Okay. Whereas the rarest of diagnosis would be considered as the most fanciest of diagnosis. So panic attack or anxiety would be the condition which is causing the mild tachycardia in a young female when you see her in the OPD. Whereas gastritis or gastroesophageal reflux could be considered as the other diagnosis. But you wouldn't think of acute coronary syndrome or any arrhythmias as being the probable cause of presentation. So for that, you need to have a concept of red flags in mind. When the symptom is like very famous, chest pain, palpitation, you should definitely think of things like silent MI, pneumothorax, endocrine disorders like thyrotoxicosis, and triage each patient according to the gravity of the symptom. If the symptom is quite famous to be a symptom presenting in the emergency, you should think of the patient as a probable case of emergency. So this is how we usually formulate differential diagnosis in the emergency department. We think of the most critical diagnosis which can kill a patient, and then the urgent diagnosis or the emergent diagnosis, and then the green or stable diagnosis. So likewise, in this scenario, for a young female presenting with chest pain and palpitations, you should think of the most critical diagnosis like the acute coronary syndromes or arrhythmias, heart blocks, or dissection, pneumothorax, tension pneumothorax, even Borhaf syndrome, more than gastritis, gastroenteritis, GERD, and pleurisy. And panic anxiety or panic attack or anxiety is the last diagnosis. So, just summarizing how the approach in a suspected emergency should be when the patient comes walking into your OPD. Do a primary assessment or a primary survey, that is to assess the patient for airway, breathing, circulation disability, and exposure along with stabilization on the go. So, if there is something which directs you to something grave, then the patient has to be immediately redirected to an emergency department. If you don't have an emergency department at your disposal, try to think of the nearest emergency to which the patient can be safely transported at that point itself. Then if you have any adjunct investigations like ECG or the saturation probe, make use of that at that point itself. If not, go in for a detailed secondary assessment. It is at that point that you take a focused ample history. Ample usually we refer to as history of allergy, medications, past medical and surgical history, LMP, last menstrual period, and last meal. Then E stands for event history. So the chronology of events could probably give you some additional clues as to how the symptoms are evolving. Then maybe think about nearby investigations like the chest X-ray or labs, and there are risk stratification scores available for each and every symptom. So if you don't know any risk assessment scores, there are ample number of softwares and apps available in the mobile. You can actually take help of all these things. And if you think risk stratification is on the higher side, definitely don't go for detailed evaluation at that point. Try to refer the patient to an emergency. These are examples, like if we are discussing about chest pain, then this is how we usually risk stratify the patient. Take a 12-lead ECG. If there is something like a STEMI or an NSTEMI, then think about cardiology consultation for a reperfusion at that point itself. If not, then think of the heart pathway or Gray score, heart score, TIMI score. There are n number of scores where you have low probability acute coronary syndrome in the offering. And then you can think of cardiac observation versus urgent care and disposition. So these are similar things for tachycardia and bradycardia. And again, for palpitations, there is this urgent care approach where if you have ruled out all the major things, you can actually think of urgent care disposition. And finally, don't forget the family physician in you when you see an emergency. Think of the 3-stage assessment: clinical diagnosis, individual diagnosis, and contextual diagnosis. Think of the whole person and also refer the patient if required. So just summarizing the take-home points. Do you want me to repeat this, or is it just okay if this is fun, right? Okay, so that's it. Thank you. Any questions?
Thank you, Dr. Nishan. From audience side, we have one question. We can have one question.
Okay, if there are no questions, thank you.
Thank you, sir, for this wonderful talk. Next, I would like to invite Dr. Anand for the next session.
Next, I would like to welcome Dr. Anand K.
I would request the chairperson, Dr. Jeshira, to hand over a memento to Dr. Nishant Menon.
I would like to welcome Dr. Anand for the next topic. Dr. Anand K. have completed his undergraduate from Government Medical College, Kozhikode, and postgraduate in Family Medicine from MIMS, Kozhikode. He is presently posted as Casualty Medical Officer at General Hospital, Thalassery in Kerala, Government Health Service. He is an EB Advisory Board member of AFPI Kerala, an executive member and faculty of Trauma Care, Kannur, an advisory board member of Kannur Dementia Care Society, besides being convener of IMALS at Thalassery, as well as member of the psychosocial support group at Thalassery General Hospital during COVID-19. He was the organizing secretary of the first state conference of the Kerala chapter of AFPI held in 2015 and organizing chairperson of AFPICON 2020. He has chaired sessions and he has been faculty at various conferences of family medicine, besides playing organizing roles in national and state conference of AFPI. Over to Dr. Anand K.
Thank you. Well, the topic today is chronic fatigue syndrome. Hope you're aware of that. Well, I know that most of you have some doubts regarding what chronic fatigue syndrome really is, but you would have already diagnosed many cases and treated without having an actual idea. That is the case with most GPs. So basically, simply put, it is a persistent and unexplained fatigue resulting in severe impairment in daily functioning. And what is fatigue, by the way? Fatigue is subjective awareness, human experience of physical and mental awareness, sluggishness, low energy, and exhaustion. In other words, it can also be defined as difficulty in initiating or maintaining a voluntary physical or mental activity. And fatigue is the main symptom. Besides fatigue, there are many other symptoms like pain, cognitive dysfunction, and an unrefreshing sleep. There are additional symptoms like headache, sore throat, tender lymph nodes, post-exertional malaise, to be very specific, feverishness, difficulty sleeping, etc., etc. And chronic fatigue syndrome is also known as myalgic encephalomyelitis or systemic exercise intolerance disease. Myalgic encephalitis because there is myalgia as a prominent symptom, and in at least some cases a low-grade encephalomyelitis has been demonstrated. But this nomenclature is still controversial, and because of the characteristic feature of post-exertional malaise, it is called systemic exercise intolerance disease also. And the prevalence worldwide is around 0.2 to 0.4%. A study in India was conducted amongst females, and it showed that about 1 in 8 of the women were suffering from chronic fatigue syndrome, that is around 12%. And the very same study also showed that older age, lower levels of education and occupational status, socioeconomic deprivation, gender disadvantage, and mental illness were risk factors. Gender disadvantage, to be specifically gender-based abuse at home. And more interestingly, 20% of the women refused to participate in the study, not because of their own interest, but because their relatives did not permit. So you see where it is going. And chronic fatigue syndrome is associated with higher mortality due to suicide, and also mean age of onset is in the 30s. So we have predisposing factors and precipitating factors and factors that promote or rather worsen the symptoms. So childhood trauma, physical inactivity during childhood, psychiatric illness or the psychopathology, and hyperactivity are all predisposing factors. And there are certain precipitating factors, especially IMN infection, Q fever, Lyme disease, etc., are infections known to precipitate chronic fatigue syndrome in predisposed individuals. And so does surgery, pregnancy, psychosocial stress, and other major life events. And the perpetuating factors are non-acknowledgement by the physician. You know, this happens very often, right? Even we might have done the same thing. Let's say a 40, 50-year-old lady comes to you and she says, doctor, I have knee pain, I have backache, FCV, I feel tired always, all the time. I can't sleep enough. How much ever I sleep, I don't feel refreshed. And we say, we just brush it off. It's all psychological. That kind of, this actually worsens. So you should acknowledge your symptoms because it's real and genuine. In fact, this pain responds to NSAIDs. So that is the thing. And negative self-efficiency and strong physical attributes. Some people, they tend to somatize everything. That people with that tendency have a predisposition to develop CFS. And strong focus on bodily symptoms. People focus on their bodily symptoms and fear of the fatigue and lack of social support, low physical activity. But all these are perpetuating factors regarding CFS. And commonly prescribed drugs like PPIs, antihypertensives, antidepressants, benzodiazepines, antihistaminics, antibiotics, etc., etc. These all can cause CFS in predisposed individuals. No definite pathophysiology has been delineated, but in some individuals, neuroimaging has showed reduced gray matter volume, but this is not at all diagnostic. And similarly, neurophysiological studies have demonstrated altered CNS activation patterns during muscle contraction, but this is also not diagnostic. Some of the individuals show some lab investigations which like modest elevation in ANA titers, reduced IG subclasses, deficiencies in mitogen-driven lymphocyte proliferation, reduction in natural killer cell activity, etc., etc. But none of this is uniformly present in all CFS cases. So none of this is diagnostic also. But there is some mild evidence which shows there is a little amount of hypercortisolism in most of the cases. And this, the degree of hypercortisolism is associated with a poor response to cognitive behavior therapy, by the way. And also these patients, these people with CFS, they tend to perceive their cognitive performance differently from what they actually can do. So that is there's a problem with their perception of their health also. So there is a discrepancy there. So you know what are the symptoms, you have a rough idea. Now you need to know when exactly to call it CFS. So you should have a guideline. So this is the guideline that says fatigue that lasts for at least 6 months. And this fatigue should be new or definite onset. And it is not the result of an organic disease or of a continual exertion. And this fatigue is not elevated by rest. Okay, and fatigue results in a substantial reduction in previous occupational, educational, social, and personal activities. This is as so much for the fatigue part. Okay, and apart from this, at least 4 of the following features should be present. That is impaired memory or concentration, sore throat, tender cervical or axillary lymph nodes, muscle pain, pain in several joints, new headaches, unrefreshing sleep, or malaise after exertion. And this also should be present for the same 6-month duration, concurrent with the fatigue, not on separate occasions, concurrent with fatigue. And there are certain exclusion criteria also, which if you find these exclusion criteria, then of course you can rule out CFS. That is medical conditions explaining fatigue, major depressive disorders, schizophrenia, other psychological disorders, and psychiatric disorders, etc. And severe obesity also. And like for any other disease, a thorough history and systematic physical examination is mandatory. And we don't have a definite, any particular one single test that can diagnose chronic fatigue syndrome. But then usually we screen the patient for other coexisting comorbidities which might contribute to the fatigue. This is a list of commonly done investigations. You might modify as the scenario warrants. You can modify the investigations. Okay. And some people want to do serology for viral and bacterial infections, but usually this is not very helpful. It doesn't yield anything. And there is no diagnostic abnormality in both CT or MRI of the brain. And of course, look out for psychiatric entities like BPD, schizophrenia, eating disorders, etc. And if a particular person has had a history of bipolar disorder or schizophrenia or anything, and if he has been treated and the disease has resolved, and at least 5 years have lapsed before the onset of CFS, onset of fatigue, then you can call it CFS. Okay, so there should be at least a 5-year gap. And chronic fatigue syndrome, chronic fatigue immediately following a depressive episode excludes chronic fatigue syndrome, but depression can appear during the course of the chronic fatigue. Anxiety and mood disorders are seen in 30 to 60% cases. And also please be very careful not to stray away from what you're trying to really help do, what kind of help you're going to do to the patient. Because many times we make the patient undergo a lot of tests, which are many times expensive and fruitless. And this we do under the intent of trying to find the hidden cause for the fatigue. Okay, but many of the time, all these investigations are futile and it's just a waste of time and money and doesn't really get you to the problem. So the initial management is first acknowledging the patient's complaints. It's very important because if you don't acknowledge, actually what happens is it worsens the patient's symptoms. Okay, that is denial from the part of the physician actually provokes an exacerbation of symptoms, it seems. And this, in fact, this is what happens. So the patient's symptoms exacerbates. Then you start believing that yes, it is because of psychological feeling, and this further worsens the symptom, and there is an unfortunate cycle of miscommunication. And the next thing we have to do is record the symptoms, duration, and their consequences. It's a very important document because a documented record will help in assessing the progress of the patient as you see them during each visit. And the symptom severity and daily life impairment should be assessed by comparing a full day description from awakening to bedtime with a normal day in comparison to a normal day prior to the onset of symptoms. Okay. So the factors that can precipitate the fatigue should be identified, and you can talk with the patient and let him be aware of what are the factors that provoke his fatigue, so that he or she can try to avoid such factors. And the severity of the fatigue is documented using a brief questionnaire. I'll show you the questionnaire in the next slide. And this can be reassessed at later visits. And if depression and anxiety are present, these are also treated simultaneously. So this is a simple questionnaire, very simple questionnaire where the patient can, you can fill up for the patient also and keep it in the records. This can be used every time to know how he is progressing. And NSCDs are helpful for management of headache, pain, and feverishness. Usually there is good relief. Even if there's a modest relief, this is very important because this translates into the patient's ability to enjoy life better and appreciate life's pleasures. So, and it becomes more self-sufficient. And also guide the patient away from toxic, expensive, or unreasonable therapeutic modalities. Because people with chronic fatigue syndrome, they tend to do doctor shopping also. They go to one doctor, they are not satisfied, their tiredness and pain doesn't go away. They go to the second doctor, go to a third doctor. And sometimes they land up with quacks and indigenous medicine stuff and all those things. So kindly, and all the same, they are very costly also. Okay, they are not very cheap or anything. So please guide the patients away from such toxic, expensive, or unreasonable or unscientific therapeutic modalities. And encourage regular sleep patterns and encourage an active life, and gradually encourage the patient to return to previous levels of exercise and work. And coming to the treatment, the only practically beneficial treatment that proven benefit is through CBT, cognitive behavioral therapy, and graded exercise therapy. And CBT is basically, today morning we had a session on CBT when we were discussing about sleep. I think you got a very detailed description regarding sleep and etc. on that session, but then I'll just brush through this. CBT is basically a psychotherapeutic approach directed at changing unhealthy disease-perpetuating patterns of thoughts and behaviors. So basically you orient the person or the patient, or make him aware of his symptoms, make him aware of how he perceives the symptoms. You change thought process, the way he looks at his problems. And CBT typically consists of 12 to 14 sessions over 6 months and helps the patient gain control over their symptoms. And graded exercise therapy targets deconditioning and exercise intolerance. Because, as I said, it is systemic exercise intolerance disease, SEID. So there is post-exertional malaise or post-exertional tiredness, right? So that is how graded exercise therapy helps. It involves a home exercise program that continues for 3 to 5 months. And walking or cycling, simple exercises have to be initiated, and gradually you can increase the kind of exercise the person is able to tolerate. CBT and GET improve fatigue by changing the patient's perception of fatigue and reducing the focus on symptoms. Then there are, of course, associated emotional issues, problems of how the patient copes up with variable and unpredictable symptoms, uncertainty about the future of personal health, feeling guilty, abandoned and lonely, loss of independence, livelihood, financial security, etc., changes of relationship with family and friends, decrease in stamina, interfering with activities of daily living, memory and concentration problems. So here you can offer coping solution where how you can help him cope with this emotional instability. Many times you will require professional counseling, proper professional counseling, where he will be able to address the feelings of anxiety and depression and grief and tackle them appropriately. And if needed, pharmacotherapy can also be initiated. And combined medication and psychotherapy might be required. And working and not working with a disability, always encourage work. Always encourage work as long as if his health or if his pain or if his body ache enables him to work, start at a very low level of activity which is able to do, so much so that which to the extent that he is he doesn't feel tired. Okay, if he's feeling tired, then bring him down to an activity that is still lower. Okay, and also if he is so sick that he is not able to work, he or she is not able to work, then it is important to make him understand and accept to cope with the fact and utilize disability benefits, if any. Okay. Now, CBT is an individualized, structured, goal-oriented form of therapy. Chronically ill patients cope with illness and develop behavior to improve symptoms. Their attitude towards the symptoms, that is where the modification happens. And this should be paced, personalized, and tailored. By pacing, what we mean is you tailor it in such a way that he is able to tolerate this activity. Make patients aware of the stresses that worsen the symptoms. And this may be combined with increased physical activity or graded exercise therapy. And of course, we need trained healthcare professionals such as psychologists who can guide a person through the CBT. If you are not really properly trained in delivering a CBT session, then I think it is better left to a good psychologist who can handle the stuff. And people in CBT should take personal responsibility for change in order for CBT to be successful. That is one important step. The patient should be made aware that he has to be responsible for his results. So his active participation is equally important. And graded exercise therapy is shown to be very helpful in a section of patients. Exercise is initiated at a very low basic level, and exercise or any similar activity, it can also be a similar activity, and you gradually increase it to a level where people can go about doing activities of daily living. Activities can be spread evenly through the day so that the symptoms are not worse. Suppose if you give an activity and he's trying to do everything at one stretch within 1 hour or 2 hours, then what happens is he will push himself too much, and that is when he will crash. Then he will develop severe fatigue and severe pain. Then he will crash. That is called the push-crash cycle. So we should your activities should be paced and given at a very titrated gradient, so that he doesn't enter the push-crash cycle. So that is called activity pacing. You break the tasks into small, manageable tasks with rest breaks in between, and take care that these activities should not worsen the symptom, and so the activities have to be spread evenly throughout the day. And too much work will result in crashing. And when he rests, he feels better. So that cycle is called the push-crash cycle. So we have to consciously see to it that he doesn't get in such a cycle. And GET should be carefully initiated and titrated. So you can start with asking him to lift light weights or stretching, or start with using body weights, like ask him to raise the hands, or then he can start using light weights, like half a kg weight or something. Then he or she can try wall push-ups, supported push-ups, then maybe chair dips, supported chair dips or modified chair dips can be done, and toe stretching can be done. And this strengthening exercises should precede aerobic exercises. Aerobic exercise or cardio exercises are more strenuous, so that will lead to fatigue more easily. So strengthening exercise should precede aerobic exercises. And people who are already bedbound or with severe dysfunction can start with just picking up small objects or grasping objects, and gradually this can be increased so that he is able to do activities of daily living. And CFS sleep issues, a lot of sleep issues are associated with CFS. Basically, they experience a non-restorative sleep compared to pre-illness experience. This is what we call unrefreshing sleep. How much ever he sleeps, he doesn't feel refreshed. So at least to practice standard sleep hygiene. Morning session was about sleep hygiene. Basically, you fix a particular time to go to sleep, and to awaken from sleep. It should be fixed time. And you also establish a regular bedtime routine. By this bedtime routine, what you mean is you, like say, you take a warm bath before you go to bed, or you listen to some soothing music. So that becomes a routine. And avoid daytime napping. Use the bedroom only for sleep and sex. And control noise, light, and temperature. Too bright light should be avoided, and noisy environment should be avoided. Keep your bedroom comfortably at a comfortable temperature. Avoid caffeine less than 6 hours before going to bed, and alcohol and tobacco less than 2 hours before going to bed. Light exercise and stretching at least 4 hours before bed, like taking a small stroll will help to achieve good sleep. And if sleep hygiene is not successful, drugs may be tried. Okay. Sleep deprivation or disruption can cause or worsen the symptoms, should be dealt early in the CFS treatment program. Sleep apnea, restless leg syndrome, recurrent daytime sleeping, etc. should be addressed adequately, because this is all part of the CFS complex. And so ensuring a good sleep hygiene is important again. Prescription sleep medications should be started if it is necessary in the least possible dose. So what are the predictors of poor outcome? Insufficient motivation, medical and psychiatric comorbidities, current disability claims, severe pain, and full recovery without treatment is very rare, and the median annual recovery rate is only 5%, but the median improvement rate is 39%, and underlying psychiatric illness of poor outcome. Patients who continue to attribute the symptoms to an undiagnosed medical condition have poor outcomes. Some people have the tendency to attribute it to something, so they have poor outcomes. So what are the take-home messages? One thing is, be aware of the entity and spare the patient from expensive and unfruitful investigations and steer them towards effective therapy. Guide the patient away from toxic, unscientific therapies. Acknowledge the patient's symptoms. CBT and GT are the only proven therapeutic interventions. Medications are only supportive and may be useful in managing coexisting conditions. Thank you.
Thank you, Dr. Anand sir. Any questions from audience side?
If there are no more questions, we'll wind up the session. I kindly request Chairperson Dr. Bijan to present a memento to Dr. Anand. I would also call upon Dr. Melvin onto the stage, kindly requesting Dr. Jashira to present a memento to Dr. Melvin. Kindly requesting Rashmi ma'am to present a memento to the chairperson, Dr. Jashira and Dr. Bijan Joseph. Thank you, chairpersons, and thank you, Rashmi ma'am. Attention all the participants of oral and paper presentation, poster presentation. Please collect your participation certificate from the registration desk. After the valedictory function, you may please collect the participation certificate from the registration desk. Kindly requesting all of you to please stay back. We are starting the valedictory function. Over to the organizing team for taking over for the valedictory function. You like to present the mementos to our workshop facilitators. Dr. Jisha, I would like to call upon Dr. Nadim onto the stage to present the mementos to the workshop facilitators. Kindly inviting Dr. Jisha to receive the award, mementos. Dr. Anaga Vijayan. Dr. Javed Reswan. Dr. Srijit Valapil. Requesting Dr. Kailas to give away the remaining mementos. We'll call upon Dr. Anima Dev. Dr. Nigeshwi. Dr. Shisha Paleri. Dr. Over to the scientific team.
Now we have the much awaited results for the oral and poster presentations for both faculties and PG students. Let me call upon one of the poster judges, Dr. Bijay Raj. Could you please join here for just comments before announcing the poster winners? You are one of the judges there. Just a comment before announcing the results.
Okay, again, this is an impromptu last minute step in, I believe. I saw, okay, let me put it this way. I did a study of my own yesterday. It was an observational study. It was a series of 5 posters selected in series, not necessarily in random. The sample size was 5. So from hospitals in 3 posters from Kerala, 2 are from outside Kerala, Bangalore area. All the presentations were very good. Out of 5 posters which were presented in the name of family medicine, 1 was not family medicine, it was mainly internal medicine. Remaining 4 we had to judge, out of which 1 came close to the concept of family medicine. None of these posters, out of this limited sample size of 5, out of around 25 posters, actually looked into the biopsychosocial aspect as a whole. There was no holistic care in this small sample size. It might be not representative of the entire 25 set cohort. And a very important take-home message is when we present posters in such events, we should not try to force the words that family medicine did this, family physician did this. No, it should be a natural part of the story. And when it comes to the question of what as a family medicine person or a trainee need to do inside, in this case, the answer should come out very pit-pat. Like, I did some counseling, I kept them in track, I monitored this, I counseled the family, I led their anxiety or brought their bill down or averted a referral or did a timely referral. Something like that should come out very clearly. So this part was also missing in this. So findings of the study are that we need to present more and more posters in family medicine conference itself, okay, so that you get tuned to how to present and what is expected as a family medicine practitioner later on in life from your mentors who will be judging the posters. And that's all. That's the only thing I have to say. So that is how you put off a study in 5 minutes. I just made it between the chair and reaching here. Thank you.
Thank you, Bijay sir. So, to declare the results of the poster presentations, let me request our scientific committee advisor, Dr. Sirin, to join along with me. And results are: the third prize in PG category poster presentation goes to Dr. Sheima NV from Muthoot, Koyanjeri. I request our state president, Dr. Indu Madam, to give away the certificate of appreciation to the winner. The third place, Dr. Shaima NV from Muthoot, Koyanjeri. And the second place, the certificate of appreciation and award is awarded by Dr. Indu Madam to Dr. Shaima MV. Madam, please stay back. The second place goes to Dr. Haifa Abdul Hakim from Lakeshore Hospital on our poster presentation on the topic dietary extremes and the prize myopathy in young. Second prize goes to Dr. Haifa Abdul Hakim from Lakeshore Hospital. And the winner of poster presentation, which was conducted on the last 2 days, 27 posters were presented, and the winner is Dr. Salima Abdul Rahman from MIMS Calicut. The topic of presentation was when arthritis points to tuberculosis, a clinical challenge. Dr. Salima Abdul Rahman from MIMS Calicut. And I also request our state president to